first time ever, a nonprofit hospital, in order to maintain its nonprofit status, which is something they want to do. Obviously, billions of dollars in tax revenue. I did a sort of back of the envelope estimate of, if you figure it's close to $1 trillion industry, even if they were for-profits, nonprofit hospitals, you might have somewhere between $50 and $100 billion in profits, which would be taxable, which would be something like $10 to $20 billion in tax revenue for federal and state governments, conservatively. So they're getting quite a bit of a public subsidy, and what this new law does is say that they need to do something in the community in exchange for that public subsidy. As we'll discuss, the enforcement mechanisms are non-existent, and there's lots of holes in this, but it's still a major change. So that's what we're going to be talking about today. Just briefly, I thought I'd introduce my panelists. David Zuckerman's on the left. He's a research associate with the Democracy Collaborative, and has written a book called Hospitals Building Healthier Communities, sorry. Closer to me is Kevin Barnett, who's the senior investigator at Public Health Institute that's based in San Francisco, and has worked a lot in the space of social determinants of health and relating healthcare institutions to community development. So let me just present a few quick slides that give some framing, and then we'll pass it on to David first and then Kevin. I start with a slide on community wealth building. This is the approach that the Democracy Collaborative has, I suppose, pioneered of trying to use ownership, community ownership of business and capital as a way of building wealth in low-income communities. So not just in terms of housing, but actual business development. And the idea is that this promotes broader ownership of capital. If you were to look at the wealth distribution here's one way of thinking about it. Housing, as I'm sure everyone's aware, is not terribly equitable in the United States. The top 1% own about 10% of all housing value in the United States. So that's fairly inequitable. If you look at businesses, however, the top 1% own closer to 50% of all assets. So if you can imagine a community where 50% of housing value was held by 1% of the population, that's our actual situation right now in the business world. So there's a large way to go. Trying to anchor jobs locally in a global economy. If they're owned by people in the community, then they're not going to move. Try to stop the leakage of dollars, increase local economic multiplier effects, support individual family wealth building, and some of these other benefits. Leveraging anchor institutions for community benefit, of course, is part of the theme of this panel. And this is a large menu, and I believe NCRC will make presentations available on their website at some point. They certainly have it. And these are some of the ones that are in bold are some of the ones that we work with most closely, but there's a whole broad range of different strategies that can build ownership and try to change those wealth inequality numbers. And so just to be aware that some of the work that a lot of folks in NCRC do, alternatives to payday lending, nonprofit financial education, clearly fit within that framework. So anchor institution, you'll hear this word a lot on this panel, so some of you may already be familiar with the concept. It's worth noting that 20 years ago the concept really didn't exist, so this is a fairly new term. It often gets shorthand as EDS and MEDS. And EDS and MEDS alone, hospitals and universities alone, are responsible for 6% of employment, $1 trillion in economic activity nationally. And one thing to note is that these last two bullets, they're typically public or nonprofit in terms of their mission. And what that means is that they actually have a responsibility to serve the public. The fiduciary duty of a board of trustees of a hospital or a university that's a nonprofit is to serve the public good. The boards of directors, the people who are on those boards of trustees, typically are corporate CEOs. It's not the way they're used to thinking. Not that corporate CEOs aren't trying to serve a public good at some level, but their main objective is to maximize profit, or increase, maximize shareholder value is how it often gets described. And so they tend to, so the boards of trustees, the people who are on those boards, tend to apply their lens even when they're operating on the board of a nonprofit. So there's an education effort and an organizing effort that's required to make this public nonprofit mission actually real. And this is what we've called our Anchor Institution Initiative, is to get anchor institutions to consciously and strategically apply their long-term place-based economic power on behalf of low and moderate income communities. And there is a growing number of institutions that are starting to do this. It's still certainly a minority within the field. Next slide, just briefly, this panel, of course, is going to focus on hospitals, which are one kind of anchor institution. There's a lot of different reasons why a hospital might be willing to take on a community mission, and so there can be mission motives. Some are religiously motivated. A lot of Catholic hospitals, for example. I mentioned the Affordable Care Act. The section is 9007, if you want to look it up, which calls for the community health needs assessment. There really is a section 9007 in the Affordable Care Act.
Did you read all of the 9006 sections?
No, and there aren't really 9006 sections because there's the 1000s and 2000s, but it is about 800 pages long. No, I didn't read the whole thing. David might have. Community improvement. So there's a benefit of, hospitals are members of the community too. They want to see their community better. And there are business reasons that are kind of interesting, particularly around supply chain. With things like Superstorm Sandy, for example, it disrupts supply chains. You could imagine lives being at stake, actually, if there's not local supply chains to get the materials they need when those supply chains break down because of storms and so forth. Hospital executives have noticed this, and so there's the trend over the last 30 or 40 years has been to centralize everything, to purchase, through a group purchasing organization, imported from who knows where, whatever what the materials are, whether they're medical equipment or food even, or whatever the hospital buys, try to get the cheapest price. They're now starting slowly to reconsider that and realize that there's more benefits to localizing supply chains. And these are some of our publications that we've done on anchor institutions, and they're, with the exception of Road Half Travel, which is through MSU Press, these are all downloadable for free on our website at communityleft.org. So with no further ado, I'm going to pass the baton to David Zuckerman. And
hi everyone. So again, David Zuckerman. I'm a research associate at the Democracy Collaborative. And for the last 2 years, I really have been looking at some of the practices that hospitals have taken with regard to economic and community development. And so that is primarily why we're here today, to say that hospitals don't just have to focus on what has been traditionally deemed the health sphere, and that there are roles for them to play in both community development and economic development in their communities. And when we think about why, it starts to get at this pie chart, which is adapted from a county health rankings at the University of Wisconsin Public Health Institute, where they have brought in a variety of determinants that really impact the health outcomes and the overall life expectancy of an individual. And so for the majority of hospitals' existence in this country, they're acute care facilities. They've been really focusing on not even necessarily access to care and quality of care, but quality of care. And then they start to move into access to care, trying to improve those who come into their system. And now with the community health needs assessment, where they're starting to identify obesity and diabetes and these other kinds of health issues that we see as problems, they're moving into addressing healthy behaviors. The argument we want to make is that you have to think of this more as a pyramid or a pie chart with looking at the social and economic factors and the physical environment as the largest piece of that puzzle. And you're only going to get so far with access to care if you don't address behaviors, but behaviors are very much linked to the socio and economic status of the individual. And so some hospitals have begun to recognize this, and the slide you saw previously was a look at some of those institutions. In that report, we looked at 6 case studies of institutions across 5 cities that are beginning to change how they are doing business. And what we see when we concentrate those, and I don't really need to tell, most of you guys know this kind of differences in life expectancy and the impact in the different communities, but for the health world, it's important to reiterate that there's a connection between all of these pieces. And what you're seeing in this slide on the left and right is differences in life expectancy based on geography within very small distances within the same city. And obviously, those communities that have much lower life expectancies, if you approach those communities, they're going to have significant challenges with regard to poverty or substandard housing. They're going to be low-income communities just because, and then there's going to be significant divestment in terms of not having access to affordable food and not having access to proper public transportation. And all of these things start to compound, obviously, and you get these life discrepancies in life expectancies within a very short geographic difference. And so what we're hoping to begin to happen with these community health and needs assessments is that hospitals begin to make this connection, and that they recognize that there are partners out there that they can work with to address some of these more upstream needs, rather than just addressing what they have originally conceived to be their role in the health sphere. And what you're looking at here is a community health needs assessment that was actually done in Hartford. It was led by the public health. I think this is a particularly impressive health needs assessment in terms of the scope of what it tries to address and lay out and make connections between. It's a 60 to 70 page document. If you look at health needs assessments from different hospitals, and we can go into the regulations, I think, more in questions, but not to bore people with like what individual piece everyone's expected to do. But what it's important to note is that every hospital, not hospital health system, but every individual hospital has to do a community health needs assessment. So there is in some way a geographic component to this. Now, there are some loopholes with that, but there is at its core a geographic component to the process. And here, what happened is, if they're overlapping geographies, they can work together. And in the case of Hartford, it made sense. You had the public health department, which there's been a big move to encourage them to be key partners in this process. We would like to see other community-based organizations, CDC, CDFIs, be at the table early on in shaping the questions and asks of the community in terms of when they do this work. But what you're seeing here on the left and right is an attempt by this community health needs assessment to identify issues of more upstream social determinants, so poverty, it's a poverty score, and on the right, a diabetes score. So throughout this health needs assessment, you'll see attempts to say, look, this is where our issues are with substandard housing, this is where our issues are with poverty, unemployment, and on the right is, and then this is where our issues are with diabetes, with obesity, with high rates of STIs, etc. And then through analysis, they've shown that when you look at why these things correlate, it really comes down to education attainment and economic security. And there is another tool that's been out there that helps hospitals address. Actually, it's a website that many folks here may be interested in. Just surveying and looking at their community. It's called chna.org. communityhealthneedsassessment.org, and it's a tool that was developed for hospitals to begin to identify the areas of most need to begin to build their health needs assessment, because there's a requirement that they can't overlook underserved communities. There's to try and avoid the donut holes that were done by banks. That this is built into the requirement that they can't do that. Now, whether that's happening or not, I think Kevin might touch on a little bit, but that is where the requirement comes, I think, for community-based organizations to say, look, we know what's going on, we know what's required, and can we hold the health institutions in our community accountable? by building the relationships that are necessary to move some of these efforts forward. And so you are seeing this begin to happen. This is another document that was actually put out by the the Catholic Health Association, along with Healthcare Without Harm. So you have the Catholic Health Association, which is like the trade group for all the Catholic hospitals in the country, or the ones that join, which is the majority of them. And Healthcare Without Harm is really started off as a community-based group that was pushing hospitals to be more involved in environmental sustainability. But it's become extremely mainstream over the last 5 to 10 years, and it has a huge membership. And for many hospitals, green is more of a priority than addressing these other determinants. And I think one of the examples that I'll talk about, partially because it's easier to measure than what impact they can have on these other more difficult challenges in the community. But what I think is important, this document only came out last year, in I believe August 2013, but it's in writing, and this is a push to get many of these institutions, the people in these institutions, to think differently. Now, the entry point for a lot of this is sometimes a little confusing, but nonprofit hospitals have to have, one last one, the Robert Wood Johnson Foundation. They put together a publication that came out just last month that cites some of the anchor work that we've been doing with the hospitals building healthier communities to say, look, we have to do this differently, and we have to fully integrate health into community development. There's this connection finally being made that it's not just important to connect hospitals to public health, it's important to connect hospitals, public health, and community development, and have them all working together towards what are ultimately the same goals: stronger and healthier communities. And to try to disconnect health from these other issues is foolish, and because no one's, there's resources not being directed towards the more important issues, and they're being directed towards addressing problems that they're only going to make so much of a dent in. So Steve talked a little bit about anchor institutions. We're here today to talk about mostly hospitals. And so just to take a little bit look at the economic impact of, zoom out for a moment. It's pretty extraordinary when we take this perspective. Now, there's about 60% of total hospitals are nonprofit institutions. Another 20% are public. Some of those public hospitals also have to do community health needs assessments if they have a 501c3 arm, which many of them do so they can attract grant dollars. There are some issues with regard to them, really following up on how they do that because they're public, they don't have all the same requirements. But so you have roughly probably about 70% of all hospitals that now have to, for the first time, look outside their walls and begin to try and at least address certain issues in the community, direct certain resources. Now, there's no requirement to how much resources. There's no requirement to what priorities in the community health needs assessment they actually need to address. They can set it based on what they think they can address, and they don't necessarily have to require community input for that second stage. So this is where the constant pressure or building those relationships to have this voice is important. I was at a convening of the folks who do this work for hospitals last week, their national conference, and one of the people was speaking and saying, she was like, oh, my public health friends, like that's how she was talking about. My public health friends finally got me to understand why we need to be addressing teen pregnancy in the community. So just making that kind of jump, or how we can address low birth infants in the community. So just begin to make that jump to, again, behaviors and everything in this world is really framed with ROI. What's the return on investment? How much can we save for the institution? Now, we can say whether really that's the intent of community benefit or not, but now that they're making that transition to look, we can actually have an impact in the community, it can benefit our bottom line, and that most of the folks that, I mean, yes, there are going to be provisions, hopefully, to get most people signed into the affordable, get health insurance, but the whole community benefit standard comes out of the fact that when Medicare and Medicaid were passed, the belief is there would no longer be uninsured people in the United States. And so a charity requirement that hospitals had turned into a community benefit standard to make it broader, because charity care was going to go away. Now, charity care today still remains the biggest portion of what hospitals count as their community benefit. And when you talk about community health needs improvement, so the actual stuff they're doing in the community, it's less than 0.5% of that. So really what it's getting down to is rethinking how we do business. This is the CEO of University Hospitals at a panel, at a conversation last year where he's talking specifically about an initiative called Vision 2010, and I'm going to talk about that shortly. And what we really want to do is go from these community benefit programs to a community benefit philosophy for the entire institution. The Democracy Collaborative, we believe that there are ways to integrate the business side of the hospital into its charitable endeavors. I put that in quotes because I mean, really, it's a nonprofit institution, and we think there are ways that it's not just giving money because it's the business side of the organization, while also supplementing those efforts with its charitable requirements. So some type of in-kind contribution through whether it's the intellectual capacity of the institution. If you think about it, I mean, if you're the people who actually do the business side of the organization, helping build capacity in the community, that's a tremendous asset. And yet oftentimes, if these hospitals, and many of them, whether they're in urban cores, there's been a history of those urban cores obviously declining, and those people who work at those hospitals driving in and driving out and not living in those same communities. So I'm going to go run through a couple examples of, I think, where we can actually think about redirecting the activities and thoughts of these institutions. Okay, wow, 5 minutes, all right. Can I have a couple of Denise's minutes? And so, university hospitals, and I want to stress that these are huge institutions that have been doing business the same way for a long time. Many institutions, their community benefit departments were also their marketing departments. Okay, and so that has been eliminated. Marketing cannot be counted as community benefit. It used to be that way, that it could. We want to get away from the idea that a health fair for just your service area or just the people coming to your hospital is community benefit. That community benefit actually has to address more than just the people that is the hospital's clientele. So it's got to move outside of, it's got to really be a broader impact. Now, it still could be rather parochial in its vision at the moment, but there's at least a framework for expanding that. So with university hospitals, and not all these activities actually fall within the community benefit framework, but it's about rethinking again how the institution actually works. So in 2005, university hospitals was beginning a $1.2 billion build out of its institution. $750 million of that was going to be construction. Cleveland is a city that has been extremely hard hit over the last 50 years. A tremendous amount of disinvestment, and really what was the factor here, partially some conversations that have begun to bubble up at the Cleveland Foundation, but really the number two at this hospital got it. I mean, it's kind of an enlightened self-interest, but it's also kind of, we have an ability to move the needle here. And so they set a lot of voluntary targets that they were going to hit. 20% from minority and women-owned businesses, 5% from women-owned businesses, 20% local hire, and 80% local. 80% of the procurement of that $750 million is going to go locally within the Northeast Ohio. And yes, you can say this is great, they set those targets, who kind of held them accountable. They hired an an outside third party to hold themselves accountable. They are a non-profit institution. They're not subject to public laws that might require this type of effort. They decided that they were going to do this on their own. They entered into a they entered into a PLA agreement that they negotiated with the unions that allow for them to actually do this, to set those targets. And they directed 92% of their spend locally, within 50 square miles. And it was real spend going into Cleveland. And so when the economic crisis hit in 2009, they were the only cranes in the air. And so you have this institution that begins to rethink how it's doing business. So in the Sinai Health System in Chicago, what they did back in the late 90s is they decided that there was a tremendous need in this community in North Lawndale, where well over a majority of the folks in the community were either returning citizens or on probation. They had done an assessment of this. And they set out to see if they started off as the fiduciary sponsor, and they lended technical expertise from their institution to help spin off the North Lawndale Employment Network. And from there, you have this social enterprise that's been started up that has really helped more than 300 people since 2007. And their product, which is, as you can see, what is this really a picture of? They have set up apiaries within actually the O'Hare Airport on vacant land there at the O'Hare Airport, and they are distributing their product to mostly specialty stores, but I believe they've also got into some Whole Foods stores. So they're trying to look for opportunities to begin to build out a revenue stream for what is the North Lawndale Employment Network to actually sustain its impact and try and begin to address some of the issues of unemployment in this community. Mayo Clinic. So this one is Mayo Clinic in the late 90s. Rochester was experiencing a boom. They were hiring people and then finding them quit 2 to 3 weeks later because none of them could find affordable housing. So they're hiring people at $40,000 a year and no one can find affordable housing. And so the Rochester Area Foundation, as a convener and kind of having the stature to be able to do this, comes to Mayo and says, we have this idea, we want to do a community land trust. Will you help us? We'll leverage those funds, we'll put in some money, we'll get state funding. And Mayo put in $4 million and then an additional $3 million upon the other folks being able to leverage it. And so really Mayo contributed $7 million to create a community land trust. And what was exceptional about this is you do see hospitals doing employer-assisted housing, but it's for their employees. This, they said, no, we're not going to restrict it just to our employees. And we're not going to just restrict it to downtown Rochester because we understand our impact is for a geography that's, we are really the anchor for southeast Minnesota. And so it's a land trust that is spread within a 60-mile radius of Rochester, and it's to date the largest community-based assisted housing program in the state of Minnesota. Okay, I'm going to speed up. So 2 more examples and then I'll end. Dignity Health, it's actually my favorite example. So I think there's real potential here if you paid attention to the earlier slide. With regard to how much investment portfolio these institutions have. I think conservatively we can say that hospitals in this country have $400 billion in their investment portfolios. 1% of that would make a significant difference in terms of redirecting it for low interest loans. Dignity Health is an institution that has an $80 million loan fund. It's a large health system throughout California, Nevada, and Texas. With these loan funds is that they really come from, if you look at the institutions that have it, there's about 6 health systems throughout the country that have these loan funds. They're all Catholic. So the Catholic health systems are, when it comes to economic justice, are actually the most progressive out there. And obviously for those who are Catholic in the room, you understand the reasons why, but it comes from a legacy, a strong legacy within Catholic tradition. And so the people who push for this, because a lot of these health systems that are Catholic were very much run by sisters, very much run by nuns. And so they helped start up this loan fund back when Dignity really began to consolidate in the early 1990s. And what you're seeing here is really where Dignity is a little bit of an exception, because they're not only willing to work with CDFIs and distribute and deploy their capital along with credit unions, but they actually step in as a loan, like they do direct lending. And with this particular project, where there was the children's museum that was wandering, there was a great opportunity to take over this school that was abandoned. Dignity stepped in as the first investor, and by them stepping in with patient capital, they were able to attract private investors who were willing to take a risk on this project. And I have not visited this project, but everything I've heard about it, that it really began to help transform this community in terms of attracting city investment to this area and really becoming a true anchor as a cultural institution in this part of the community. And Dignity was paid back within 2 years. So for them, they've had a near 100% rate of return, partially because they are willing to be a patient lender. They're willing to step in and say, we're not going to foreclose on you. That doesn't look very good for a hospital. We're willing to renegotiate and make this work. But they do 0 to 5% interest loans, and for them, they help allow CDFIs to reduce their rate. They're able, the rate of interest they're charging on a loan. So they're able to work in that kind of way. Lastly, I'll talk about one last project in Cleveland, which is really to help actually stand up employee-owned business in specific disinvested communities using the procurement opportunities of those institutions. This is a project that Steve and I at the Democracy Collaborative have been a part of. And to date, there are 3 businesses that stood up, and I can talk more in detail, and Steve can also in the question period since I'm over time. But to date, 90 employees with the goal that each of them will have investment accounts. So this is a multi-stakeholder cooperative for the individual co-ops that are part of this larger network. The employees there that become members have investment accounts. And so for a community where the average median income is under $20,000, that allow these folks to perhaps build equity through the profits of these businesses that are very much linked to the procurement opportunities at these institutions. And to give one example, University Hospitals, which has really been a tremendous leader, has just redirected 2 million pounds of its laundry to Evergreen Cooperative Laundry, really putting it into the black and putting it on a firm footing. And this laundry is 2 miles from the institution. So we have these are just a few ideas where we can begin the conversation, and there are a lot of others, perhaps more in the in traditional community development, other institutions that are doing great work too. But unfortunately, I'm going to skip this because I'm off. But and then I'll turn it over to. Well, lastly, I'll say on this. You don't want to tell me this. All right. Because I won't hear the end of it from my boss. This is a tool that we put out to try and begin the conversation about where we would like the institutions to measure their impact. And as you can see, it's mostly dominated. In some ways, reflects the social determinant pie chart earlier. We need them to think about community investment. We need to have them think about equitable local and minority hiring, how they can be doing, in addition to most of their efforts are in healthy community residents and healthy environment. We need them to be thinking above the line, or at the top of this, and working their way down. And this is something that we're hoping to pilot with local universities and hospitals in the coming year. But we hope that this report is free on our website at communitywealth.org/indicators, and so feel free to download it, look at it, and see if it might be something that can help guide conversations in your community. So thank you, and I'll turn it over to Kevin.
My training is in public health and city and regional planning. I began doing this work about 20 years ago, in particular looking at ways in which to get hospitals to be more strategic about how they invest in low-income communities. My focus, because of my training, has been on how to help hospitals move their thinking upstream. Before I got myself overeducated, I worked as a community organizer for a number of years. And when I began, after my education, looking at these write-ups on state statutes beginning to be passed on community benefit, and seeing how they were being called upon to really engage diverse community stakeholders and look at ways in which to address these issues, I was a little quizzical, because my experience had been in working with a lot of local collaboratives is that if the hospitals did come to the table, they really only came to a few meetings. Maybe they wrote a check, but they usually didn't stay involved in these processes. And the way that a number of states, California and Texas, Pennsylvania and others, were writing their statutes really talked about them being much more engaged in an ongoing way in this work. So I was struck by that. I began to do some research, got myself labeled an expert, and I've never been able to escape this work since. But it's a very exciting time right now. There were certainly times in this work I felt a little like Don Quixote, a voice in the wilderness, because while there are some hospitals and health systems that are doing outstanding work in this arena across the country, for the most part, we're still on a pretty steep learning curve. David referenced the early passage. This is an initial ruling from the IRS. You can listen to some of my presentations. So what happened was, as David indicated, there was concern in the hospital industry that because we were going to have all these people covered with Medicare and Medicaid, we weren't going to have this drive for charity care. And there was a drive to really expand this notion of how we define community. This is, the typical legalese used by the IRS. The promotion of health for a class of beneficiaries sufficiently large enough to constitute benefit for the community as a whole. And it really drives the thinking towards, number one, how do you measure this? Because you need to identify that class large enough. And then it should lead you to, well, where are these problems concentrated? Because if you want to measure something, you want to focus where the needs are greatest. So there were a lot of other rulings that came out, but this was really the driver. This was passed in 1969. So this was a lot of the way that things happened. I think as Steve mentioned, there was a lot of the orientation of marketing, but for all intents and purposes, there was somebody that was gathering everything we did that we could possibly imagine as qualifying as a community benefit. I know tree compounds were all necessarily included, but this is sort of an amusing framing of that. So what's happened now, again, and I'll touch on this at the end of my talk, and I want to move through this fairly quickly. This is a small group. We ought to have a dialogue. So think about some of the questions, what's going on in your community, what ways in which we can help support your effort. So with the IRS put out the revised 990 beginning in 2009. There's been a number of notifications since this time. And then as both David and Steve mentioned, there was Section 9009 in the ACA. It really is, it captures the core, which is the requirement to conduct a community health needs assessment and the requirement to solicit input. But there are a range of other elements that hospitals are supposed to address in the reporting requirements. In fact, it represents the most comprehensive increase in transparency and potential accountability for hospitals, literally in modern history. But even outside of that, how many folks read Bitter Pill in Time magazine a few months ago? If you haven't, I'd encourage you to look at it. It's frightening when you look at the billing and collection practices of a lot of hospitals, as well as our pharmaceutical companies and equipment manufacturers. This is really going to drive thinking and public accountability about how we address this. They're also beginning to be more and more of a push to look at what are the reimbursement levels for different procedures. This is the drive from revenue to value and how we hold hospitals accountable. So we're going to have more and more ability to look across the board at what hospitals are doing. And then outcomes are beginning to think beyond simply the ROI for the institution, but really what's the larger ROI? If you reduce absenteeism for childhood asthma in the local school, it doesn't just benefit the hospital if these are uninsured patients, it also puts dollars in the pockets of the local school district. LA last year, LA Unified School District lost over $1 billion from absenteeism in the schools. That's revenue it didn't get because kids didn't come to school. So that's a lot of money. That's one school district. So the other issue, and I'm going to focus on this as we talk about defining community, it really makes a world of difference where hospitals are located. Your degree of proximity to low-income communities, your payer mix, what jurisdiction you're in, and the degree to which you're focusing on the social determinants of health. So there's a broad set of questions that are being raised. I would note, my colleagues mentioned this issue of there's going to be more accountability as it relates to the IRS. I question at this juncture, particularly the other dynamics that are going on in the IRS, whether they're going to have the capacity to have the kind of accountability to really hold hospitals accountable beyond simply the $50,000 charge they get if they're not conducting a community health needs assessment. Fundamental accountability is going to be at the local and the regional level. Are we asking the right kinds of questions? We ought to be asking them to hospitals, and if we're not getting the answers from our hospitals in our region, then we ought to be asking public officials these same kinds of questions. I'm going to touch on that a little bit. So this is called the Community Health Improvement Data Sharing System Project. This is a project that we just completed with funding from the Centers for Disease Control and Prevention. We said, let's take a snapshot. Let's look at what we have, because hospitals are required to post their community health needs assessments in a very obvious way on their websites. They are supposed to submit an implementation strategy within the same fiscal year to the IRS. Many of them, to their credit, are putting them up on their websites as well. We wanted to look across the country. We did a random selection of 15 sites, 4 large metro, 4 small metro, 3 micropolitan, and 4 rural. The one common criteria in each one of those regions was that there was a sub-county concentration of where 30 to 40% of the residents were 100% under the federal poverty line. We also used a similar metric, and both of these are proxies for health disparities, was the high school non-completion rate. We looked at it at a similar level. So there were 51 hospitals in these 51 sites. We were able to get 44 community health needs assessments and 27 implementation strategies. So this is one of the problems with some of the language. The IRS encourages hospitals to define their geographic community within their service area. There's also other language, the time won't allow me to get into this in detail, where it's confusing. On one hand, they tell hospitals, you can't define your community in a way that would exclude communities with disparities, but then they've added in their most recent notice language in that same sentence that says as long as it's within your service area. So one of the net results of the lack of clarity is that less than a quarter of the hospitals in these regions identify these geographic areas where disparities are concentrated. We don't know whether or not that's a function of whether or not they explicitly tried to exclude that, whether they went to their marketing department and said, where are 75% of our discharges? We're have a follow-up the next phase of this study to look at and engage them and find out why this occurred. And again, we're going to release a public report of this. We're going to blind all of the results to protect the partially innocent. This report will be out in the next couple of weeks. But it's really intended to say, it's a wake-up call to say, folks, here's the kind of information and here's the kind of questions that you could be asked at the local level. We know many of you are just doing this for the first time. Here are some things that you ought to be thinking about. So I think I pretty much covered this, so I'll go beyond it. I'll just note that one of the things that we are finding as we're engaging both hospitals and local health departments across the country is that they're all doing, for the most part, they're doing their assessments by themselves. In states where state statutes have been passed some years ago, there's more of a history of collaboration, although I would say collaboration is probably the most overused and misunderstood term in the English language. They have at least come together and engaged a consultant and pooled money to have them conduct the community health needs assessment for them. But for the most part, after that, everybody takes their toys and goes home. So part of this is how we begin to move those together. But we have got over a third of the nonprofit hospitals out there are critical access hospitals. These are hospitals of 25 beds or less. And almost all of these are doing their own assessments. Doesn't make any sense. Same thing for the 2,600 local health departments across the country. Most of them conducting their own health assessments. This is a theme I'll come back to as we move forward. So we used, I can't remember if Steve or David mentioned the chna.org. It's a fantastic website, full public access. There are over 7,000 layers of data that you can upload into this GIS platform and look at it. One of the tools within chna.org is called the Vulnerable Populations Footprint. You go to this and you plug into the window any city or county anywhere in the country, and it'll automatically upload the two proxy metrics I mentioned, the percentage population of the federal poverty line, high school non-completion rate. It'll also upload the hospitals in that particular area. You can upload jurisdictions, and it'll also upload the community health centers. We use this, and again, I blind this result, so we don't know where this is. But here's how two different sets of hospitals define their service area. The tan area in the middle is the area where there's a concentration of poverty and associated health disparities. So the area in lavender is how two hospitals define their service area. As you can see, they included this area of concentrated poverty. The area in black is how two other hospitals define their community. You can see it almost looks like a gerrymandered district around the areas of poverty. Again, we don't know whether or not it was an explicit attempt to avoid serving these people. The other thing that's on this map in green is are the census tracts that are 100% above beyond the top quintile of income. So these hospitals that define their area around here are much closer to these particular areas. This is another example where you see the hospital in green jump over this county in the middle to include this county. There's no hospital in this county, and there's a concentration high school non-completion. Again, we don't know why that is. We're going to follow up in So in any event, there are a number of other aspects that we looked at in this study. Again, all the IRS addresses with hospitals is the degree to which you have solicited input. You have considered input from community stakeholders in the community health needs assessment. Nothing about when you're setting priorities, nothing about what you did with the input in the community health needs assessment process, and nothing about whether or not you engaged them in the planning and implementation process. So here's what we saw across the board in terms of the engagement in the community health needs assessment in the priority setting and the implementation strategy. A dramatic fall off of these groups. This reflects a focus on compliance rather than how do we really move this agenda forward. So I won't focus on this much except to say, as it relates to priority setting, this is another area. It's sort of a public health kind of activity, but hospitals are required to submit information on the process they use for setting priorities and the criteria. What we saw in a lot of the criteria is the criteria wouldn't allow you to select among options. A criteria is not, we were informed by our nonprofit charitable mission. That doesn't allow you to select between whether we're going to invest in violence prevention or childhood obesity. So there's more learning to be done in this regard as well. There are a growing number of public policy tools out there. Payment in lieu of taxes were some of the first, but there's a determination of needs, for example, in Massachusetts. Hospitals are also getting community benefit agreements. This is confusing terminology. It's usually used in broader economic development, but that same frame is being applied. There's a hospital in San Francisco that had to put up money for a community benefits agreement in a targeted area as a result. And there are informal requests. There are local ordinances. The one criticism that I have, and the problem that I have with these in general, is these leave the hospitals intact. All they have to do is to write a check. And really what we're trying to get them to do is to transform themselves. One of the big issue here, and this has been inferred by both of my colleagues, is what's happening now is we're beginning more and more to enroll people in lower income communities. And as we expand and move towards full employment, and as we move towards global budgeting, hospitals are going to be at risk for serving these populations. And given that medical care only counts for about 10 to 15% of what creates health, they're going to need partners to work with to address the social determinants of health in communities. So that drives us to really think about the issue of convergence. Again, I won't spend any time on this given the time. This is a set of guidelines put up by colleagues at George Washington University that really are about where we ought to be going in community health improvement. What we've done is highlight, here's what you have to do in terms of compliance. Here's what really moves us forward into transformation. Again, we can talk about this more in our dialogue. So what this does is outline all of these entities are doing assessments out there, including the CRA Performance Context Review for hospitals. That is retrospective, but all the others are looking forward. Banks can do more prospective kinds of assessments if they want to go that extra mile. But we're really looking at how to begin to push this thinking. So we look at how these entities define communities, how they engage community stakeholders. I would note community action agencies are in 95% of our communities. And they have pretty strict requirements, pretty strict focus in areas where disparities are concentrated. There's no reason why all of these entities ought not to be working together. So the biggest challenge, just in wrapping this up, in hospitals is an environment of crisis management. They're completely overwhelmed now with information systems development, with buying physician practices, preparing for the new constraints on reimbursement. It's really hard to get the attention, particularly for the people that are doing community benefit in hospitals. They tend to be lower level staff. So unless you have somebody in the senior leadership that's really championing this, it's hard to move it forward. And frankly, most of the CEOs that I've talked to, they don't know what they don't know. When you talk to them about population health, for the most part, they think of it as a panel of patients. They're not thinking about people in the place-based context. So there's education that needs to be done in that arena. I think the priorities moving forward are inherent in what I've been talking about, but really there's no excuse for avoidance of targeted investment where our disparities are concentrated. This is where we need to do the work. David did a great overview of Dignity Health. We're in the process of putting together a piece that really highlights this is an important area of investments for hospitals. I think Dignity's up to about 100 million now. They're really looking at ways in which to increase this kind of investment. There's a group of hospital chief investment officers we're meeting with at the end of April to really try to get more investment of this kind across the board. So this is just an effort to capture this broader collective impact approach. We're engaged. How many folks have heard the term collective impact? If you haven't, I encourage you to just Google it, and it's an excellent article. This is a group, FSG, that's based in Boston and San Francisco. What they have to say isn't really new, but it really captures what many of us have been trying to encourage for a long time, is really engaging in efforts where you have mutual reinforcement. So whether or not a hospital is focusing primarily on population health improvement, whether it be a variety of focus on reducing obesity, if we can begin to align this work with targeted investments by financial institutions in very focused communities, then we have the potential to really achieve some exciting things. We're engaged with funders now to look at ways in which to put a national initiative in at least 8 to 10 sites around the country where we can move this agenda forward. So last slide is the blue arrow really captures where we are. We started with random acts of kindness and community benefit 20 or 30 years ago. We had some really good innovative work, but we sort of ran off and left the clinicians behind. Now the work is how we make this a core part of the business strategy for hospitals, frankly, because they need this. Probably 15 to 20% of the hospitals are going to close in the next 10 years. The ones that are going to make it are the ones that are really engaged in this work, and we're looking forward to working with them on that. With that, look forward to engaging you in a dialogue.